And of course, there will be always a few people coming in late. But so welcome everybody to the CMR Journal Club of this week. We have two exciting papers, both focused on strain, which is kind of an incoming parameter. So strain has been around for a long time, but methods to assess that have, to say the least, they have not been ideal. But now it seems that with MRI, we have a somewhat more reproducible way of measuring strain. And there are several strains, and we will probably discuss that later. But it seems that certain forms of analyzing strain, be it longitudinal or circumferential, are better than others. And we still need to learn a little bit. And there have been two fantastic papers that we will discuss today. And I want to already thank Christoph René from Bern and Julian Lütkens from Bonn for joining today. And we'll start with Christoph René's paper entitled Diagnostic Performance of CMR Segmental Myocardial Strain for Detecting Microvascular Obstruction and Late Enhancement in Patients Presenting After ST Elevation MI. So Chris, if you would share your screen, welcome and thanks.
Just try to share it. Yeah. Not sure whether you can see it.
Yeah, we can see it. As usual, okay, we just walk through the paper, and if there are any questions, please post them in the chat, or then just unmute yourself and speak up. So, Christoph,
yeah, perfect. So, Matthias, thank you very much for the invitation. It's always a great pleasure to be invited to this great format of online discussion of interesting CMR papers. I really appreciate that, and you're really pushing the field very much forward, and it's always a pleasure to be a part of it. As you mentioned, you said it's a very exciting paper. I think it's an okay-ish paper, but still, yeah, maybe we can go through. So the question what we posed ourselves was like whether we could use strain imaging to non-invasively and also to without contrast detect MVO, microvascular obstruction patients after myocardial infarction. So I highlighted a couple of interesting parts in this paper. I will quickly walk you through. So microvascular obstruction, also called MVO, in patients after ST segment elevation myocardial infarction is a known predictor for a bad outcome. And of course, then it would be very favorable to have an early detection of MVO, because this would impact on your clinical decision making towards treatment. CMR is an absolute fantastic tool to not only depict the dimension of the left ventricle and the function, but also you can nicely depict the tissue characteristics, as we know, like the enhancement for the scar quantification, and also in when you have areas where no gadolinium is going into it and it appears purely black, then we call this a so-called no-flow phenomenon. It's endocardial, and after myocardial infarction can be present and is called MVO, microvascular obstruction. Now, what we did in this study, we took consecutive patients after STEMI who underwent PCI. This is a sub-analysis of the CARE-AMI trial. CARE-AMI trial was a trial where paroxetine was tested to whether this could have an impact on the positive remodeling after myocardial infarction, which didn't show. That was published before. And we took this cohort and looked whether we could have a good diagnostics with regard to strain in these patients. What we did is a scan 3 days plus minus, so 1 to 3 days after the MI, so pretty acutely, and we acquired routinely short axis images, 8 millimeter slices without gap, 3, 4, 2 chamber U, and gave Gadovist 0.2 millimole per kilogram. We did the tissue characteristics and used the 5 standard deviation approach for the local enhancement, and where we could depict no flow MVO, that was called no MVO, and beside MVO minus, like no MVO, we also categorized the patients in LG plus, MVO plus, LG plus, MVO minus, and LG minus. So these 3 groups. It's very nice. You do not need to have a specific sequence to depict strain imaging. You can use routinely acquired images, and then using post-processing CVI42. I think it's an absolute fantastic tool. I recommend that. And also the newest version has this AI button where you can have very fast a proposition of the software, and then you just need to adjust it a little bit. So we use maybe 5 to 10 minutes maximum to adjust that. And then we could depict the different strain values, for example, segmental, circumferential peak, segmental longitudinal peak strain, compared also to the global strain. In these patients, then we maybe just shortly statistical analysis. As I said before, we have these 3 groups: LG plus, MVO plus, LG plus, MVO minus, LG minus. And we looked at on a segmental level. So we used the AHA model, and we looked at each segment whether this was categorized in either one of these 3 categories. We did a derivation group of 30 patients, which led to 480 segments, and we used the validation group to see how good the performance of the diagnostics was. We used the ROC curves, and we assessed scar versus no scar in the ROC curve. We assessed MVO versus no MVO in the ROC curve, and also we looked at within LG plus, within the scar, whether MVO can be differentiated or not. We also looked at the ICC, the intra-class correlation coefficient, and looked whether it was, how robust was the inter and intra-observer variability. So I would like to move to the results. As I said, 50 patients with anterior STEMI, purely anterior STEMI. That is just because this was one of the inclusion criteria for this CARE Army trial were included, and 2 were then excluded because they withdrew after the inclusion. At the end, we had 48 patients, and you see most of them had like really significant infarctions, because we have LG present in 83% of the patients. Then we compared it, and LV was of course lower in patients with MVO compared with patients without MVOs. And when we go on the segmental level of strain, you see that 146, that's around 20%, had LG plus MVO, and around 40% had LGE plus, however, no MVO, and about 40% of the segments had no LG. When you look at this, that's not very surprising. Segmental circumferential strain was, of course, significantly different between all categories, and was worse in patients with MVO and LG, a bit better in patients with LVO but without MVO, and of course was the best with minus 17.4 in LG negative segments. When we look at the diagnostic performance regarding scar, that means LG plus versus LG minus, we could show a very nice area under the curve for 0.848 with an optimal cutoff of minus 13.8. And then we applied this, so this is the derivation cohort, to the validation cohort. And there you can see that it's yielded to a sensitivity of around 76%, specificity of 74%, positive predictive value of 81, negative predictive value of 70%, which was pretty similar in a segmental longitudinal strain. When we look at MVO plus versus MVO minus, there on the curve is a little bit less, 0.76. Cutoff was minus 11.2, so much lower. And when we applied this cutoff, the sensitivity was around 80%, and specificity a little bit lower, negative predictive value 94, pretty good, positive predictive bad. When we looked at MVO within the scar, you can see that the sensitivity was 80%. However, the specificity was not so good, but importantly, the area under the curve was not so good. So within the scar, it can be pretty challenging. Reproducibility of segmental strain is good, which is very nice to see. And so we can conclude that in patients after an anterior STEMI, we have a good diagnostic performance for detecting MVO plus segments and very good diagnostic performance for LG plus segments. Now, here, maybe you can just see the table. This is the total population, MVO plus 40 patients, MVO minus 8 patients. And here, I think this is also important to see the ROC curve, MVO plus versus MVO minus. So this leads to this area under the curve of 0.84. For LG, it's pretty similar. However, as you can see within the scar, very difficult to say whether there's LG, whether there's MVO or not. So of course, this can be something very nice for the future if we can come from contrast to contrast-free images to maybe better risk stratify these patients. Maybe we can in the future also translate this knowledge from CMR to echo, which is much more available. And when we maybe can use echo as a very simple tool to have a fast idea of, let's say, ruling out MVO, this could help in the future the physician. Maybe also strain can be applied to depict other complications of myocardial infarction like thrombus, etc. So I think the future is really great, and I hope that we could somehow also contribute here a bit to the knowledge of strain and where strain could be applied. So thank you very much for your attention, and I hope you have some questions for me.
Yeah. Thank you very much for the nice and concise presentation. In the interest of time, we will have to just focus on a few questions. So then, of course, from a clinical point of view, the main question may be, what do you think about the specificity? Because if you talk about strain, you're basically talking about regional dysfunction, just looked at it from a different angle, the deformation instead of just the overall shape of the wall as a whole. So what do you think about the specificity of this versus ischemia or scars coming from non-ischemic disease? So I think you made a great point. We should try all the options that could lead us to a non-contrast enhanced MRI scan. So would you feel comfortable now with this? And then what is your idea from a clinical point of view?
Yeah, thank you very much, Matthias. That's really a good question, of course. And I mean, we would like to translate that to the clinical practice, but I think it's just too early. This is really preliminary analysis. This is done in only selected patients, anterior infarction, very study-specific setting, anterior infarctions only, as I said, and also, you know, I think the sensitivity is not too bad. I think if it's all normal, then it might be used as a tool in the future to exclude. But I think, as you mentioned, maybe your critical question about the specificity, I think it's still too low, and maybe we need to go a bit deeper into segmental strain. Maybe we should apply also layer strain. I mean, I would be very much interested to see, like, what happens when we look at the endomyocardial strain, mid-myocardial strain, epicardial strain, and maybe also the gradient over that. And maybe this could in the future also give us a bit more insight on whether this is also a method which might be in the future also more specific. I think we need more data, of course, larger cohorts with other infarctions. We need also maybe other analysis. And of course, at the moment, I am not confident enough to make a clinical decision.
Yeah. And last question. Often you see the no reflow, if it's significant, or the MVO in the native cine images. Have you done some comparative analysis whether that would also work?
Yeah, that's actually a good question. What we sometimes also have some questions is whether it's thrombus or not. Let's say if it's MVO, it can sometimes really appear very similar to thrombus, especially when it's adherent to the wall. So anyways, I think it's sometimes not super conclusive. MVO in scene images is a good question. I haven't looked into that, whether this could be also possible, but definitely that's a good idea.
Yeah, because there may be also options of tissue characterization with native images based on T1 and T2, because the source of MVO, from my point of view, in significant MVO is very often hemorrhage and reperfused MI. If too long after the initial occlusion, very frequently, and we've looked at that, at least half of the patients have myocardial hemorrhage, and that's very often what then leads to the extensive MVOs, and this has significant prognostic implications also, not just because of functional lack of functional recovery, but also persistence of iron in the tissue, which leads then to electric instability and down the road to a higher rate of sudden death. So interesting papers from Rohan Dharma Kumar in Los Angeles. So, but thank you very much, Chris. If you could unshare your screen. So
thank you very much.
We go to the next one, also on strain, and I'm happy to welcome Julian Lütgens from Bonn, and he will present a paper with the title Layer-Specific Strain Analysis with Cardiac MRI Feature Tracking in Acute Myocarditis. So, Chris, you already mentioned layer-specific strain analysis, so Julian will present a paper that used that. So
let's look deeper into the layer. Thank you, Matthias, for this kind introduction. Can you see the PDF page?
Yes. Yes.
Okay. So diagnosis of acute myocarditis can be challenging, given the various causes and clinical manifestations of the disease. And on cardiac MRI, we have the Lake-Lewis criteria, where we look for edema and also inflammatory lesions on LGE imaging. But the detection of myocardial dysfunction can be more challenging in myocarditis. And this is also why systolic left ventricular dysfunction is also only a supportive criteria in the updated Lake-Lewis criteria. But why is this exactly the case? So I want to go a little bit deeper into the methods. So myocardial structure and function is heterogeneous due to a layer-specific fiber orientation, ranging from largely subendocardial orientation here at the midwall to more oblique or longitudinal orientation at the endocardium and the epicardium. And there's also a gradient in myocardial strain across the wall with increasing values from the epicardium to the subendocardium. So the strain or the contraction is more prominent in the endocardium, and in acute myocarditis, we typically often see the subendocardial involvement, but the surrounding myocardium, this is still healthy, and also the subendocardial myocardium is still healthy, and this myocardium contracts normal, and this is why we often don't see any wall motion abnormalities in maybe uncomplicated acute myocarditis. So MRI feature tracking can improve the detection of myocardial dysfunction because it's a quantitative tool and doesn't rely on visual analysis. And in this study, we wanted to evaluate the diagnostic performance of cardiac MRI feature tracking layer-specific strain analysis in patients with a suspected acute myocarditis. So we performed a retrospective study, and we screened our myocarditis patients in the system from 2014 to 2018, and all patients had a clinically defined diagnosis of acute myocarditis, which is important that if you look for parameters like sensitivity or specificity, you know that this is like an artificial cohort, and you have to look carefully at the diagnostic values of single parameters. And patients mostly had an infarct-like presentation of acute myocarditis. And we also identified healthy controls who undergone cardiac MRI for study control reasons. So the cardiac MRI protocol was pretty standardized. They all underwent the same MRI protocol, including CNA imaging, edema imaging, and late gadolinium enhancement imaging, and also myocardial mapping. And for analysis, we calculated ejection fraction and diastolic volume, evaluated every parameter which is recommended in the Lake-Lewis criteria, and also calculated LG extent, which was calculated using the full width at half maximum technique. So, and then we additionally in this cohort did a layer-specific strain analysis, which we derived from a dedicated software, and the software was QStrain, and it's from Medis medical imaging system. And within the software, you can draw contours at the endocardium and the epicardium, and then they are propagated throughout the cardiac cycle. And the software gives you like the peak systolic global longitudinal strain from four-chamber CNA images, and it gives you the systolic global circumferential strain and the systolic global radial strain from short axis images. And what the software also do by default, it calculates for the longitudinal strain and the circumferential strain, it calculates 3 distinct strain parameters by default at the subendocardial level, at the mid-myocardial level, and at the subepicardial level. So altogether, we have now 7 strain values, 7 global strain values, which we analyzed in this study. And we also subdivided the cohort of patients with an acute myocarditis in a group with preserved ejection fraction and reduced ejection fraction. And if we go to the results, so we could include 70 patients with an acute myocarditis and 42 control participants. And they were matched by age, and also the gender distribution was equal, and cardiac MRI was performed around 3 days after admission. Let's have a short look at the clinical and cardiac MRI characteristics of the both groups. So the myocarditis patients had, mostly every patient had an elevated troponin. They had elevated markers of inflammatory disease with an elevated C-reactive protein and white blood cell count. And the ejection fraction was slightly lower in these patients. And also parameters of myocardial inflammation, they were increased. What we also had is that 90% of the patients had visible late gadolinium enhancement. And when we quantified this, it was only 5%. So there were also patients that only had a subtle late gadolinium enhancement. And if we look at the location, we found that most lesions were at the subepicardium and the mid-myocardium, and we only observed diffuse transmural enhancement in 8 patients. And we didn't observe any sole subendocardial enhancement in these patients. When we look at the strain parameters, we can see that there are group differences between strain parameters between myocarditis patients and controls, except for the subepicardial circumferential strain. When we closer look at the strain parameters, we can see, for example, here for the global circumferential strain, that there is this gradient from subendocardial to subepicardial, so with higher values at the endocardial levels and lower values at the epicardial levels for myocarditis patients and controls. And what we can also already maybe see over here is that the group discrimination, for example, for the circumferential strain is best at the mid-myocardial level. So you can see here that there is no overlap of the boxes, which is the case for the endocardial and the epicardial strain. When we look at the longitudinal strain, we see that the group differential or group discrimination is best for the epicardial global longitudinal strain. When we compare healthy controls with patients with a preserved left ventricular ejection fraction, we can see, or we found that only the subepicardial longitudinal strain and the mid-myocardial global circumferential strain could discriminate between healthy controls and patients with a preserved left ventricular ejection fraction. We also looked for correlations between strain parameters and other cardiac MRI parameters or other inflammatory cardiac MRI parameters. And here we found that among all layer-specific strain parameters, the mid-myocardial global circumferential strain showed the strongest correlation with other cardiac MRI parameters. And this is what you can also see here on the heat map. I highlighted the mid-myocardial global circumferential strain, and you see over here the correlation coefficients. And you can see that the correlation coefficients were highest for mid-myocardial global circumferential strain for the correlation with T1, T2, ECV, LGE, and also left ventricular ejection fraction. Now have a look at the diagnostic performance of the 7 evaluated global strain parameters. And we can see that the subepicardial longitudinal strain had the highest area under the curve with 0.77, or the second highest with 0.77, and the highest area under the curve had the mid-myocardial circumferential strain with an AUC of 0.882. And these were the 2 best performing myocardial strain parameters in our data set. And we also calculated the area under the curve for the classic Lake Lewis criteria, and there we had an area under the curve of 0.92. And when we added these both strain parameters to the Lake Lewis score, then we found that we could even further increase the diagnostic performance of the score, and we gained an AUC of 0.97, which was statistically significant compared to the Lake Lewis criteria. So in conclusion, we can say that among all evaluated strain parameters, mid-myocardial global circumferential strain and subepicardial global longitudinal strain showed the highest diagnostic performance for the diagnosis of an acute myocarditis. And the inclusion of these two strain parameter also significantly improved the diagnostic performance of the 2018 Lake Lewis criteria. And within the discussion, we can say that the mid-myocardial and subepicardial strain parameters were more affected than subendocardial layers in acute myocarditis, which makes also sense when you think of the inflammatory lesions in an acute infarct-like myocarditis. And on the basis of common anatomic and pathophysiologic concepts, it can be assumed that myocardial dysfunction depends on the predominantly affected layer in different cardiac diseases. So this might be an interesting concept to test, like also accord maybe with myocardial infarction and acute myocarditis, and show if you can discriminate between 2 groups with an layer-specific strain analysis. And we also observe correlations between circumferential strain and markers of inflammation and edema, which indicate a link between systolic dysfunction and acute myocardial injury. And yeah, so we concluded that layer-specific cardiac MRI feature tracking strain analysis might be more sensitive than the common endocardial approach, which might be pathophysiologically explained. So thank you very much.
Thank you very much for a great presentation of this fantastic work, Julian. You have already done a lot for the field of myocarditis, and this may be a strong indicator that strain may eventually put the function, as you indicated already, into a conventional criterion for the Lake Lewis criteria, because it has a discriminative power, especially as you pointed out, because it's so different from ischemic lesions, where the problem is more in the longitudinal subendocardial fibers. So great work. Chris, you have a question.
Yes, very nice presentation, Julian, and congratulations on the publication of this work. I have a question. Is it also possible to do segmental layer strain, or did you try to somehow get this data out of your outputs?
Yes, this is possible with the software. But so this is a study I wanted to make like for 8 years, and we didn't have a software who can do this layer-specific strain. And if you do it then segmental, you have so many strain parameter, and it's so overwhelmed with data. And also your tables, you can get lots of tables out of the software for every patient, and it's just overwhelming. And for this work, I just wanted to make it simple, because we had this pathological idea what layers might be affected. And this really turned also out in the study it's very good. And yeah, and I was really excited about the proof of concept, actually.
Yeah.
Great.
Dr. Rafi from Montreal, you have a question. Go ahead.
Thank you so much for your excellent presentation. I wonder that is it possible to use this method for diagnosis of subendocardial infarction as a non-contrast cardiac MR? Do you have any experience?
So instead of giving,
research?
You do, if I understand correctly, you have to do a native scan and you don't apply contrast and then make your diagnosis with the software.
Yes, with layer strain study.
Yeah, it might be possible, but so the great advantage, I would say, of late gadolinium enhancement is that you can see the dead tissue, because we all know that bright is dead. And this information you won't get from layer-specific strain analysis. So in this analysis, you can see, okay, that there is a severe subendocardial wall motion abnormalities, which might be because of a myocardial infarction. But we know we can also have like an atypical stress pattern or all kind of diseases which can also do wall motion abnormalities. So I would be careful, just use the strain software for diagnosis.
Okay, thank you. In the interest of time, just allow me one more quick question before we have to call it a day. What do you think is the actual spatial resolution? Because that's, of course, a question. If you have a wall that's just, let's say, 6, 7, 8 millimeters, and then the images themselves, we know each pixel kind of bleeds with its information to the neighboring pixel. So what do you think is the actual spatial resolution? It apparently was good enough to discriminate the different layers, but is there a limitation, or do you think we're in a comfortable space there?
Yeah, there might be definitely some limitation if you look like for wall thinning in ischemic heart disease, for example, where you have a really thin wall. I think this might be difficult, but also in the thin wall you won't have any contraction anymore. But but I felt very confident with the software, actually, and also the tracking was very good.
Yeah, so that's also good that there's good software out there to help with that. So one last question from Carlos. Would you feel comfortable providing a cutoff point for strain using feature tracking?
Not yet. So this was a research study, and we only don't do this in clinical routine. So in clinical routine, you look at the MRI very fast. You see if there's an LGE lesion or if you have wall motion abnormalities, and then you need another software, load the images in, and so we don't use it in clinical routine now.
Okay, thank you very much, both of you. Before we stop, I wanted to just point to the next journal club, which will take place, of course, beginning of October, first Wednesday, and we'll present these two papers. One is from the team from Johns Hopkins, published in European Heart Journal Cardiovascular Imaging, and called Myocardial Fibrosis by T1 Mapping. MRI predicts incident cardiovascular events and all-cause mortality. And that's from the MESA trial. So it's about prognosis, and the same for the other paper from an Italian group from Florence, published in Frontiers in Cardiovascular Medicine, called Metabolomics Fingerprint Predicts Risk of Death in Dilated Cardiomyopathy and Heart Failure. So next month it will be about prognosis and using tissue characteristics for predicting outcomes. Thank you very much, Chris and Julian, for the fantastic presentations. Thanks everybody else for joining. I wish you all the best. Stay safe, and until sometime soon. Bye.
Bye.
Thank you very much. Bye-bye.